SAESP tem uma preocupação em auxiliar o desenvolvimento da anestesia, em auxiliar o seu desenvolvimento como profissional, para que nós possamos cada vez mais cuidar melhor dos nossos pacientes.
Boa noite a todos. Eu sou o Luiz Marcelo Malbouisson, eu sou professor de Medicina Intensiva da Universidade de São Paulo. Estou aqui para apresentar hoje um seminário sobre hemodinâmica utilizando métodos não invasivos. O nosso seminário de hoje ele vai ser conduzido por dois professores, o Dr. Manning, da Duke Health General Vascular and Transplant Anesthesiology Division, e pelo professor Yude, da Mayo Clinic, da Cleveland Clinic, e será dirigido em duas partes. A primeira parte, que passarei a palavra agora, é para o Dr. Manning, que vai falar de além da pressão arterial, o valor adicionado de ver a circulação. Dr. Manning, please.
Okay. Well, thank you for having me. You can see the slides now?
Not yet, doctor. Can you share your screen again?
Yeah.
Temos um problema técnico.
Yeah, it's on.
You can see it now?
Yes.
Okay, good. So a few disclosures. I do have financial relationships with Rutia Medical, and I do write educational content for Up to Date. And everything I'm going to talk about is my own experience with the Rutia monitor. And I just want to stress that the clinical decision-making that each practitioner uses should really be the focus. So a few learning objectives that I wanted to start off with, and this is how I teach a lot of this physiologic background to our trainees. I want to start off by discussing and distinguishing arterial pressure from blood flow and explain why that normal pressure can accompany inadequate perfusion. And then we'll talk about flow-guided decision algorithms that I use in my clinical practice and try to highlight some of the dynamic indices such as stroke volume variation and when they're unreliable and how to select a good test to make sure that the data you're getting is accurate. And then we'll go through some cases to highlight the current goal-directed therapy evidence. So as anesthesiologists, what are we optimizing? We're really optimizing for oxygen delivery, which is cardiac output and arterial oxygen content. So certainly some things that we can do, we can optimize hemoglobin concentration and fractional inspired oxygen. But what's also important to note is actual blood flow and the arterial pressure for this flow. And there is this conception that pressure equals flow, but that's not always true and accurate. So we need to focus more on flow and blood delivery to the tissues. You can have situations where the mean arterial pressure looks good, it looks fine, but when you look at the cardiac index and what you're actually delivering to the tissues, this can be quite low. So a couple of equations that I use a lot in my teaching to focus this is cardiac output and heart rate and stroke volume. Now we can easily measure heart rate with our monitors through EKG monitoring, but stroke volume is kind of hard. right? Stroke volume is affected by preload and the volume status of the patient, the venous tone, bed positioning. Afterload is more the systemic vascular resistance and vascular tone, and contractility, obviously, sympathetic tone, electrolytes, ischemia, the need for inotropes. And multi-beat analysis, such as the Argos system delivers, it allows you to display cardiac output and cardiac index and stroke volume directly from arterial lines that you place. So you can really see which determinant is failing and where you can intervene on low blood pressure a little bit more accurately. The other equation I use a lot is the systemic vascular resistance. Now, most of us all remember this and have memorized this for our exams, but rarely do we, I think, reflect back on that during episodes of hypotension in the OR. So as you may remember, it's mean arterial pressure minus CVP over cardiac output. And what I think is key here is that as systemic vascular resistance starts to fall off, cardiac output is inversely related to that. So that's going to go up. And kind of the classic teaching for that is in patients with severe sepsis and you have vascular dilation, the cardiac output will go up significantly and you'll have a high throughput cardiac failure where the tissues aren't able to extract oxygen as efficiently. And so you'll have a worsening acidosis despite the fact that you have a very high cardiac output or a normal cardiac output. And so the addition of a vasoconstrictor becomes important. But when you're in the OR doing regular cases and you just have blood pressure, you don't really know, is this a vascular tone issue? Is this a drop in your SVR? Is this an inotrope issue, a contractility issue, or what have you? So my background is as a cardiac anesthesiologist and a liver transplant anesthesiologist. And so I come at this with a real strong bias to the cardiovascular system. And we all remember the Frank Starling curve. And what I want to know as a practitioner is, which curve am I sitting on? Am I sitting on a reduced EF curve where I'm at a unfortunate point on the slope, or am I at a normal point operating in optimal contractility for my left ventricular end diastolic volume? Because that's important, because patients are often treated, I have found, with fluid first. And if you're sitting in an ineffective or a low cardiac state or cardiac contractility state, fluids aren't the answer. We want to be up higher to really achieve a volume status or a fluid challenge. And so where I think the Argos system really shines is the ability to take your arterial waveforms and analyze multiple beats, giving you a much more robust signal versus some of the other devices that use a single beat pulse contour. And I have found when I use this system and compare it to TEE, it's very, very accurate. It's very robust in its data that it gives me. And its lag time is 15, 20 seconds, which is very, very quick for this kind of data that I'm getting. And the algorithm that I personally use when I'm evaluating patients with hypotension, I'll start by looking at the mean arterial pressure, and then I'll look at the data that I get to see if stroke volume is changing. And then I'll then consider the underlying contractility and assess cardiac index. So is this something that needs fluid? Does this need an inotrope? Do I need to do something else? Do I maybe need to actually add a vasodilator? So I tend to build out a flow-guided decision map where we're looking at hypotension or a low flow state, and I'll read off the data that I get, and I look specifically at systemic vascular resistance and stroke volume, and I'll look at those numbers and then determine if stroke volume variation is changing, is it not changing? If it is, then I'll give a fluid challenge and I'll look to see if I'm vasoresponsive. If not, then I'm going to look at tone and I'll look at inotrope, and I might give a small bolus of epinephrine to see if contractility is the way to go, or if I need to give a vasodilator. So I want to go over a couple of cases kind of to highlight some of these examples. So the first case was a robotic nephrectomy that I was taking care of, and it was a 76-year-old woman with a single tumor in her kidney that we were removing. Patient was in a lateral position, jackknife, and the pneumoperitoneum was in place. And the case was going along very nicely, very stable. But then there was an abrupt fall in stroke volume and cardiac output, and the blood pressure was following. And this is a depiction of the data that we got from our RTIA over minutes. And we gave a fluid bolus thinking that maybe somehow we were a little volume behind. That was not responsive. We gave a little inotrope bolus, wasn't responsive to that. And what we found after we ran those numbers and did our little challenge tests, we talked to the surgeon and asked, are you bleeding in the field? Because we're not responding to the things that I would normally think of. Our cardiac output had been 2.8 liters and our index was 1.4 at the time. Our stroke volume variation was 12%, which is a little borderline, but our stroke volume had dropped considerably, almost by a third of what it had been. Our systemic vascular resistance was normal. And what we found was that when the surgeon led up to kind of evaluate the surgical field for any bleeding, that he was actually pulling a lot of tension inadvertently on the vena cava. So it was really restricting venous return for us. And so once they let up and changed the retraction, the patient recovered very nicely. And you can see how quickly her hemodynamics recovered from that. A second case I took care of several months ago was an 86-year-old gentleman undergoing a major aortic reconstruction. It was a complex dissection. It was a long 5-hour case. And I'm sure everyone's seen this, that when they release the aortic cross clamp, pressure drops very quickly, and the reflex would be to give volume. But having the data that the cardiac output was preserved, and you see the systemic vascular resistance has collapsed, we know that volume is not really going to be the answer for this. So our cardiac output was robust. It was 6.2 liters. The stroke volume was normal to a little bit high from what it had been. The stroke volume variation was 8%, but the systemic vascular resistance dropped significantly to about 500, which well on the low range of normal, and the mean arterial pressure was significantly low. So very quickly gave some boluses of vasopressor and asked the surgeon to reapply the clamp in a partial to allow us to kind of get that vascular tone back. So had we not had this device and we just saw hypotension in that setting, we were able to very nicely target our interventions and our therapy to what the patient needed, and I think really minimize the time that we stayed hypotensive, both in this case and the first case. Now, the third case to kind of exemplify some of this physiologic principles. We had an elderly patient, 71-year-old, for prolonged major spine surgery with a multi-level. And the mean arterial pressure was sitting at a comfortable 68. No alarms, the anesthetic looked smooth, but on the Argos, when you started looking at the trends, the cardiac index had quietly been drifting down for about an hour. Everything else looked fine, it's just this was slowly drifting off. And with major spine surgeries, blood loss can kind of creep up if you're not paying attention, and you're going to get a little bit behind. And I think that's what we were seeing here. So the mean arterial pressure was normal. It was a 68, which was within the range that we had set for this patient based on their baseline. The cardiac output was a little low. The cardiac index was starting to drift down to 1.7, and the stroke volume had drifted down as well. Stroke volume variation was creeping up high. And so what we saw was that the flow was slowly trending down and needed some fluid. A check on the ABG before we started giving some blood and some volume showed a lactate of 3.8 and a slowly developing metabolic acidosis. So another case to kind of show what this is capable of, we did a lung resection, and while we're lateral with one lung ventilation, using protective low tidal volumes with the chest open, low tidal volumes on the dependent lung. The blood pressure was starting to soften up and get a little hypotensive, and the stroke volume variation read only 4%. And so taking that at face value, this would be a case where you would say, I don't think fluid's going to be responsive. And so what we noticed on the Argos was the stroke volume variation at low tidal volumes was falsely low. But when we did a couple of recruitment breaths, notifying the surgeon before we did it, we saw that the stroke volume variation after a volume challenge was quite responsive. And so we gave some volume, the patient perked right back up. The last cases I use as an example was with cardiac surgery and separation from bypass. Now, at our institution, we typically don't use pulmonary artery catheters in patients with preserved ejection fractions. Everybody obviously gets an arterial line, but having this kind of a monitor helps us in the period after separation from bypass. And the filling was adequate on TEE, and the patient was not vasoplegic. Cardiac output and the stroke volume remained low. The pressure was propped up by rising resistance. And what we then elected to try was a little bolus of epinephrine, and found that the patient was responsive to that. And so we went up to the ICU on an inotrope, volume filled, no need to give a vasoconstrictor, which would have made any acidosis worse. Not what we want to do. We certainly didn't need to give any more volume, but titrating solely to an inotrope was what we needed. So again, when you look at these flow charts and how we manage patients, case 3 and 4, they were volume responsive. So stroke volume and pulse pressure variation was kind of the way to target that. Case 1, when nothing else fits, then you can kind of say, okay, there's something else going on, and we can interrupt the surgeon, and found that there's something actually going on in the field. In our case, it was an aberrant retractor holding pressure on the IVC and really hurting our venous return. In case 2, a low systemic vascular resistance where cardiac output was quite high. And in case 5, like we just discussed. So before treating pressure alone, I try to get people to think about the cardiac output and stroke volume. And the one question I want people to ask in the OR is the patient fluid responsive? Are they adequately filled? Because if the tank's not filled, then squeezing or inotropes are just going to make things a little bit worse. But test it and test it with a valid maneuver. Match the intervention to the mechanism. So if you're needing fluid, give fluid. If you need a pressor and the systemic vascular resistance is majorly low, give the pressor. So you're becoming a much more targeted, personalized intervention rather than just a one-size-fits-all. Well, I gave vasopressors, that's not working. Then I added an inotrope. Oh, well, that's not working. And then I gave fluid as the last thing. That may not be the right order. So individualizing the evidence, I think really rewards and moves us away from being very reactionary to being a lot more anticipatory. So these are some of the references that I used. All right. A couple of questions I see. Could you please explain a bit more in detail how the monitor is able to calculate systemic vascular resistance without requiring a central venous pressure? So this is a derived measurement. So systemic vascular resistance is a derived calculation. I don't know the exact equations that they're using. I believe that's proprietary and beyond my expertise. Maybe Dr. Uday knows the particulars about that. But what I have found is that as a trend monitor, it is very, very good at gauging systemic vascular resistance. And one of the cases that I think highlights that very well for us is the patients that I take care of for liver transplant that come in with ascites. We were talking about this before the lecture started. Patients with ascites will appear euvolemic up until the abdomen is open and the ascites is drained, and then you unmask the relative euvolemia and you find that you are hypovolemic as the systemic vascular resistance is mechanically alleviated from that compression and you vasodilate up. And on the Argos, you can see very, very clearly the systemic vascular resistance will drop within 10 to 15 seconds as that ascites is relieved. And so that allows us to fill the patient back up and to add a vasopressor appropriately. Are there any clinical situations in which this calculation of SVR may not be reliable? I think in the extremes of bed positioning, in patients that are undergoing a robot prostatectomy, where the head is down below the heart and the legs and the rest of the body are way above the heart level. We have measured central venous pressures around the heart to be somewhere around 30, 32. Again, that's kind of variable based on patient size, age, fluid status. But I think at that extreme, the SVR calculations may not be accurate as it would be in a supine patient or a patient that's supine and lateral. But I think as a trend monitor, I think it would be still an appropriate gauge. Again, in the broader clinical context of what's going on, you have to, I think, pay attention and look at, the trends and the evolution of the case.
Thank you, Dr. Manning, for your lecture and for answering the questions from the audience. First, I'll be back in Portuguese. Inicialmente, de novo, eu queria pedir desculpas, mas é importante dizer que esse webinar está sendo patrocinado pela Neste, que é a empresa que trabalha com esses dispositivos, que traz esse dispositivo Argos. E agora, dando continuidade a este webinar, vou convidar o Dr. Udê, que é professor de anestesiologia intensivista da divisão de terapia intensiva e ressuscitação da Cleveland Clinic de Ohio, que vai falar sobre qualquer paciente com uma linha arterial é possível monitorizar o débito cardíaco. Dr. D, the room is yours.
Thank you. Good evening, guys, and thank you so much for inviting me. I will try and build on what Dr. Madden has sort of given us a good physiological basis for what we're talking about. So in terms of disclosures, I have served on a medical advisory board for Massimo, and I've consulted for GE Healthcare. And my objective is really today to talk about this emerging technology of non-invasive or less invasive hemodynamic monitoring. And I was going to understand how you can help you understand how you can apply the data from the Argos to guide hemodynamic management of patients. But I'm not sure I'm going to do a better job than the real life examples that Madden shared with you. And then finally, I'll just give you a little bit of history of how we began to adopt this device at Cleveland Clinic and how we're using it today. All right. Dr. Manning did a fabulous job of really highlighting what we all know. There was this paper that was published a few years ago, that kind of tried to use machine learning to define the types of hypotension in the operating room. And surprise, surprise, it came up with everything that you and I already know. And Dr. Manning did a fabulous job of really explaining some of that pathophysiology, right? We measure blood pressure with a cuff or with an arterial line because it's relatively easy. And so when a patient's hypotensive in the operating room or in the intensive care unit, it's either they're bradycardic, right, which would be easy to tell, or it could be one of these other three variables here. It could be loss of vascular tone, they could be hypovolemic, and it could be a pump problem, a cardiogenic problem, right? Or it could be a mixture of all of these. And so being able to define which one of these factors is at play is crucial, right? Dr. Manning put it right, match the intervention to the problem. Historically, we would just give fluids because, again, that is quick and easy. But that only addresses one of this. It doesn't address all the other variables, right? And so how do you figure out which one of these things is going on in your patient? Historically, we would do things like at the bedside, use a PA catheter or in the operating room. And that was one of the first bedside tools that was available to clinicians to use. Now it dates back to the mid-century, 20th century, but really until the 1970s when Dr. Swan and Gans devised the PA catheter as we know it today, there was really no good way of doing this at the bedside, no easy way. And then, of course, ultrasonography, echocardiography advanced, and so TE and transthoracic echocardiogram became another tool in our pocket. But as you can imagine, these are fairly invasive devices to use and require a certain amount of skill, not just to interpret the images, but to obtain the right numbers and to be able to interpret that and then apply the right treatment that a patient requires, or no treatment if that's what the case is. And of course, we keep looking for other devices to help us. Esophageal Dopplers came out in the late 90s, early 2000s. And all along, folks have been looking for ways to translate the arterial waveform into some estimate of some of these advanced hemodynamic parameters, whether it be cardiac output or stroke volume or SVR. And many of the devices that are on the market, and some that have gone off the market over the last 2-3 decades, took various approaches. A lot of them tried to extrapolate from the Wink-Kessel phenomenon, Wink-Kessel model, that kind of models the cardiovascular system, assuming it's a 2-compartment model, and tries to give you an estimate of what cardiac output is. The problem with a lot of those approaches, we'll talk about that a little bit more later, is that we're analyzing a single arterial waveform. And the reality is that the waveform that we're measuring from arterial lines in the peripheral circulation is not just reflecting forward flow. It's also reflecting all the reflections that come as the blood flows from the aorta towards the periphery. The vessels get narrower. There are branches from those vessels, and each of those branch points, and as the vessels get narrower, you begin to get reflections from those waves. And so what you're seeing at the end in your radial artery or in your femoral artery is a composite of forward and backward waveforms. And so that distorts what you're seeing at that individual waveform level, and doesn't truly reflect what you see at the central circulation in the aorta. And I will talk about this a little bit more. And then we're also, folks also working on completely non-invasive monitors that don't require an arterial line. And these are just beginning to emerge. And but we're not going to spend our time on those because they're not, maybe just a couple on the available for clinical use right now. And each has their own problems. But the PA catheter was one of the first tools that was really available for clinicians at the bedside. And it was, doctors jumped on it because, hey, we finally have something that helps us differentiate what the mechanism for our hypotension or shock is so that we can properly address it. And by 1985 in the ICU, almost at least 1/3 of patients in the ICU had a PA catheter, right? It's funny because I remember as an intern in my first rotation in the ICU, back then bedside ultrasonography was not there, or fluoroscopy wasn't always available, so there was a lot of blind sticking, and it was a big production for the fellows and the staff to get a PA catheter placed. And after maybe an hour and a half of work, they would go off to do something else, and the intern, who has no idea what they're talking about, is left to manage the patients. I had no idea what the PA catheter was. I couldn't interpret the numbers. And I was the one left to manage the patients overnight or in the afternoon, right? So was there any surprise that the outcomes were not what we were expecting? By the mid-90s, observational studies after observational studies were showing that patients who had PA catheters had a worse outcome. And I know now that it wasn't the PA catheter, it was the whole process of placing it. The relative compared to what we do today, you had a tiny drape, not a full body drape. The risk of infection was high, multiple pokes to get into the vessel because it was being done by landmark and not ultrasound guided because ultrasounds were not available back then. And so you can imagine the amount of injury that just came from placement, let alone the interpretation or misinterpretation of the data. And so not surprising, the use of PA catheters plummeted. Whether it be in the operating room or in the ICU. In fact, I have colleagues now in critical care who have gone through the entire critical care training and never placed a PA catheter once. That's how far the use has decreased in the ICUs. By the early 2000s, less than 2 patients in every 1,000 admissions in the ICU get a PA catheter. Now, there's a more recent meta-analysis in 2025 in surgical patients that found that there was no association with short-term mortality in non-cardiac surgical patients. And I think this is reflecting what the true state is, because now, even though we're using it less frequently and more selectively, there's better understanding of the use of it, right? Unlike back then when everybody got it and folks didn't really know. Again, using my example, my personal experience where the intern was left to deal with the patient. But there was an association with a high incidence of major complications and longer ICU stays in cardiac surgery patients. And so the challenges we have in trying to get the data to help us define what sort of problem we're dealing with so we can match our intervention to the problem is one of clinician expertise, right? Whether you're doing a PA catheter, placing a PA catheter, even with ultrasounds today, or TE or echocardiography, you need a certain level of expertise to be able to do this. And then this information is not continuous, it's sporadic. If I have a TE, it's only if I'm looking at the TE am I going to make a decision. There's no continuous monitoring. And if I don't have the expertise, and then I can interpret the images I'm looking at. If I'm doing a transthoracic echocardiogram, I can tell you, I'm sure you've all experienced it when you have someone with less experience giving you foreshortened images or not being able to obtain the correct views. And so you can't really utilize that without a certain level of expertise. And then, of course, the cost of complications. And now, as we started moving into the less invasive devices that depend on arterial waveforms, one of the things that I'm sure you all know from the experience or seen from the experience is that all of these come with proprietary disposables. Well, either you have to change your transducer to use a specific transducer, or there's a specific tubing that has to go with this, or some other disposable that has to attach to the patient. Then, of course, these disposables have to be stored somewhere. Someone has to set them up. Some of these devices require calibration and frequent recalibration. And then the questions of device accuracy begin to come into play. After all these caveats, how accurate it is, right? If it's a device that requires recalibration once or twice a day, or several times if you've made significant changes in your vasopressors, if you don't keep up with those recalibrations, then your measurements begin to drift. And so going back to our slide about the endotypes of hypotension, it becomes clear that the tools that can help us do this in a continuous, less invasive manner are going to be crucial. Dr. Manny made the point that giving fluids is not always the answer. It's the easy thing to do. You don't have to wait for pharmacy. The heavy fluids are right there. But too little and you have the higher incidence of complications, and too much, you run into the problems with hypovolemia, pulmonary edema, peripheral edema, and the cycle, skin breakdown, become a portal for entry for bacteria, and then your patient who was doing well now gets septic. So fluids is not always the answer. But how do you find that sweet spot in the middle where you're giving just enough fluids to make sure that you are not either keeping your patient under-perfused or over-perfused, right? So the Kahneman made that point, and he gave great examples. How do you assess the likelihood that your patient is going to benefit from fluids? This is where care protocols come in very handy. Being very proactive in defining how you assess the patients to determine which mechanism is driving their hemodynamic instability, and then tailoring your intervention to that. And Dr. Manning's examples were spot on. If you can do that proactively and properly, you do end up with fewer days in the ICU, fewer days in the hospital, and overall better clinical outcomes. And these have been well demonstrated in the literature. And so for you to, if you're picking a non-invasive device to use to assess advanced hemodynamics, it becomes important that that device should be able to track fairly accurately the changes in cardiac output, not blood pressure like we talked about, but cardiac output, right? And why is that important? If you're not accurate, or if your response time is very slow, then you lack the ability to detect any positive intervention or negative, positive response to your intervention or negative response to your intervention. At the extremes, accuracy also becomes important. And then response to intervention, right? We talked about fluid boluses, and we're going to talk a little bit about fluid challenge, right? If you are not able to get a fairly rapid and a fairly accurate response to your intervention, then you lose the ability to detect the signal you were looking for. Did my patient respond or not respond? Do I need to continue with fluids, or do I not? Do I stop? Is it a vasopressor problem, a vasodilatory problem, and is there a response to that? So that ability to track quickly and reliably becomes very crucial. Now, the Argos monitor will get, it picks up the standard parameters from the bedside monitor, the miniature pressure, heart rate, and blood pressure. And then you can derive the rest of these parameters from the monitor. So cardiac output index, stroke volume index, and then the dynamic parameters of pulse pressure variation. What I liked about this device, which is why we began to adopt it, was the simplicity of use. I talked about how many of these other devices on the market as it came on the market were not just the cost of acquiring the monitor, but also the disposables or an ongoing cost, right? This doesn't have any disposables. It's a single cable that goes from the back of this device or the monitor and plugs into the back of your bedside monitor to pull the arterial waveforms from there. And so it doesn't get any simpler than that. There's nothing to attach the patient. There's nothing that touches the patient. And so you avoid the cost of disposables. You avoid the cost of storage. I don't know about your ICUs, your operating rooms. No matter how big we build them, there's never enough space. And so the more things you have to, the more disposables you have to have on hand and store, the more difficult your life becomes in general. And so underlying technology for the Argos is really a multi-beat analysis algorithm. It was derived several years, early part of it this century, at MIT and Michigan State. And the key about the multi-beat is it analyzes multiple beats over 20 seconds to start, and then you have it rolling 20 seconds. So it updates every 5 seconds after the initial 15 to 20 second lag. And what's critical about the multiple heartbeat long interval analysis is when you analyze multiple beats over time, you begin to mitigate some of the confounding effects of those wave reflections I talked about. So at that point, the whole system begins to look similar to what you would have expected with a Wynn-Kessel model, and you don't have those confounding effects. And so changes in rhythm would not affect the assessment as much as with some of these other devices that depend on analyzing one single arterial waveform. And then in terms of how this works, really, what is unique about this compared to the other devices is all of these devices have some assumptions about the patient and the patient's physiology. Many of them make assumptions about the vasoconstriction state of a patient, or the SVR, which is why when there are extreme changes in SVR, they lose accuracy and you have to recalibrate for the ones that are calibrated. Or if it's an uncalibrated one, then you begin to see a drift in accuracy, right? So if your patient now goes on several pressors and your SVR changes, they begin to lose accuracy. Now this Argos, the multi-beat analysis part of the underlying algorithm, is that it directly estimates SVR. So it models the multiple heart waves, multiple heartbeats, and generates a composite heartbeat. And from there, it then estimates the diastolic time constant. So the time it takes for the arterial pressure to decay in diastole is estimated. Now that time constant tau is calculated as a product of resistance, your SVR, and compliance. Now, arterial compliance. Now in humans, your arterial compliance doesn't change very quickly. It changes over time, months, years, which is why as we all get older, there's a tendency for us to develop hypertension because we begin to lose compliance. So it's something that you can use a nomogram, if you will, to be, and you'll be fairly good, you'll have fairly good stability in your estimates because compliance doesn't change over quickly. Whereas SVR can change with your state of agitation, with your fight or fear response, with bleeding, whatever is going on with your patient can change SVR second by second or minute by minute. And so by being able to directly estimate the tau by applying an exponential to the diastolic component of that arterial waveform that's been modeled, you get that estimate of systemic vascular resistance, and then you then apply that into Ohm's law to calculate your cardiac output. And so, this is why it's a little bit more robust compared to some of the other competitors that make an assumption about SVR and then model cardiac output as a factor of pulse pressure. Now, so we've talked a little bit about how it works, and we talked about how it's important to understand what the mechanism of disease is. One thing I like about this device is it's got a built-in guide that can help you determine pulse pressure variation. And we know this is important because this study was done in cardiac surgery patients. In 50% of these patients, over 3,000 patients who were hypertensive and hemodynamically unstable, only 50% of them were fluid responsive. Whereas at the bedside, if you didn't have some method of determining whether you needed fluid infusion, you would give these patients fluid. So half of them were getting fluids that they did not need. Now, to do a fluid responsiveness, you can either do a passive leg raise in the ICU, or you give a small fluid bolus, and you want to then calculate estimate the change in stroke volume. And this is where the responsiveness of the device to be able to give you that change within 5 seconds after the initial 15 to 20 second lag can then help you determine, yes, did I have an increase in my stroke volume with the passive leg raise of the fluid bolus. It's important to know that not every fluid responsiveness, when you do the challenge or the passive leg raise, your MAP might only increase by 10%. And so looking for an increase in blood pressure may not actually give you the response you need, depending on the ability of your measurement tool to give you a rapid indication, a rapid response to the intervention you've made. And so looking for the MAP might not be ideal. What you really want to do is look at the stroke volume. And this is where having a tool like this that can give you continuous SVR and continuous SVB in a fairly rapid, responsive way becomes useful. And so this tool's got this Argos does have a way of doing guiding you through that and then letting you know what the response is. Now, I can't give you any better examples than Dr. Manning did, but this is an example of a patient whose MAP looked good. If I saw this in the ICU, I'd be like, everything is hunky-dory. Don't have to worry about this. And then I get further information, and the index is 1.5, and SVR is over 2,000. And suddenly I realize there's been an oxygen debt that's being accumulated that if you do not pay attention to that, will then eventually show up with an increase in acidosis and all the other adverse complications that can emerge from hypoxemia. And so being able to monitor cardiac output continuously may be one of your first tools to realize when something is going on behind the scenes. This study was just published a couple of years ago, looking at cardiac surgery patients. The reason a lot of these studies are done in cardiac surgery patients is, for the most part, those are patients that still, I don't want to say routinely, in some institutions still get PA catheter monitoring. So that's often used as a clinical standard, clinical reference standard, not necessarily a gold standard for measuring cardiac output. So during this study, these patients had TE, they had the Argos monitor. So they were being monitored. The clinicians were not blinded. And yet there was an average duration of 86 minutes of low cardiac index throughout the entire case. So these were patients who were receiving treatment, who were being, the clinicians were responding to whatever they thought they needed to do. There was no restrictions on what the docs could do. And yet there was an average of 86 minutes of low cardiac index. 61 of those pre-bypass and 25 of those post-bypass. One of the things that came out of this was that MAP and cardiac index were modestly correlated. And 69% of the time during which these patients had low cardiac output, their MAPs were within normal limits. 69% of the time with low cardiac output, the MAP was within normal limits. So these were patients who were accumulating an oxygen debt in the operating room during cardiac surgery. These are the most monitored patients in the world, whether it be in the ICU or in the operating room, and yet this was still happening. And of course, not surprisingly, the duration of the low cardiac index was associated with an increased risk of acute kidney injury at 48 hours post-operatively in these patients. And so there is a price we do pay if you do not detect low flow. And we do know now from all the data and evidence we have that your MAP could be full in, your MAP could be normal, and yet you're accumulating an oxygen debt. And so when we think about the Argos monitor, obviously we talked about accuracy. The PA catheter is often used as a clinical reference standard, not necessarily as a gold standard, but because it's not a gold standard. Gold standard is a flow probe on the aorta directly, which we can do to every patient. But when you've compared this in off-pump CABG patients, with the comparing the Argos and the flow track compared to the thermodilation with cardiac index. The concordance rate in terms of changes in cardiac index for the Argos compared to the thermodilation was about 87%. Same study, same group of patients with the Vigelio was only 72%. And I think this reflects what I kind of talked about, the differences in how they estimate cardiac output and their resilience, if you will, or robustness to changes in SVR and arrhythmias and things like that. Similarly, in patients with cardiogenic shock, about 22 subjects, 101 pen measurements, the mean difference was less than 0.2, less than 200 cc's. Concordance was 94%. So typically you want to see concordance rates above 90%. And this was a study comparing the Argos with the transesophageal Doppler monitor. It was done offline. The data had been collected and the analysis was done offline. 572 measurements, 58 patients, same thing. You could see fairly good concordance rate of 93%. So what we do know, for the reasons I described, the multi-beat analysis will accurately track changes, whether they be due to pressures or fluids, and it does that with a fairly rapid response time. And just kind of summarizing some of this. So these studies were looking at patients who were having cardiac surgery, liver transplants, some neurosurgical patients, and postoperative in the ICU. And one of the things that was I guess positively surprising was the robustness in the setting of arrhythmias, atrial fibrillation, in this case in post-cardiac surgery patients. Because it looks at multiple beats, it's able to mitigate the impact of arrhythmias. Now, and so summarizing all of that, in ideal world, we would all have real-time ability to monitor some of these advanced hemodynamics in our patients. When you compare this in terms of reliability relative to the clinical reference standard of a PA catheter, it has shown fairly good concordance rate. And Dr. Manning talked about how he's compared it to his assessments with transesophageal echocardiogram and how it's been fairly concordant with that. Then trending during arrhythmias and low output states. And then finally, the ease of setup and the lack of disposables. This is actually a good segue for me to how we started using this at the Cleveland Clinic. We were using the flow track and LITCO, and I believe there was a couple others. As our health system began to grow, we were trying to harmonize equipment and devices. So our docs and nurses and fellows and residents, as they went from ICU to ICU or hospital to hospital, they would see have access to the same type of equipment and not suddenly be faced with something they didn't know. As you can imagine, if you have 3 doctors, you get 5 opinions about the same thing, and we could not get consensus. This was mid-2014, 15, 16, and when the Argos came out and we realized there was no need for disposables, there was no need for to purchase, because that was another thing we were faced with. Well, who's going to, you buy the device as a capital purchase, and then the budget for the disposables goes in the nursing, and nursing doesn't want to do this, and then the storage, and we couldn't get agreement with everybody. But once the simplicity of use was demonstrated, the nurses were very ecstatic, because now they didn't have to take down the transducer they already had and switch it to another transducer to use a particular device or add some tubing. Basically, much less work for the nurses. And then for us, from a cost point of view, without having to pay for disposables and storing disposables, and then comparing the clinical results with some of the other devices we had, folks very quickly decided to start using Argos. Now, the interesting thing was we didn't say you couldn't buy LITCO or flow track anymore. We actually didn't say that. Those just died naturally over time as folks started using this. And you can see every year since then, our numbers have grown. I believe we have about 80 now, and every year we add a few more. So that's my last slide, and I will take questions. Thank you for your attention.
pessoal, depois de duas excelentes apresentações sobre fisiologia da avaliação hemodinâmica e sobre uma nova tecnologia de monitorização hemodinâmica, o chat está aberto. Se vocês tiverem questões, façam em português ou inglês. Necessário, eu traduzo-as em português para inglês. Enquanto isso, eu vou fazer uma pergunta para o Dr. Ude e para o Dr. Manning sobre a tecnologia. Thank you, guys. Very nice presentations. I would like to ask you if this technology is validated for all age ranges. Can I use in a child or only in adults?
Good question. Just adults. I believe there are studies ongoing to validate this in children, just adults. And also for radial and femoral arterial lines, we're about to start a study to look at brachial arterial lines because we use a lot of brachial arterial lines in our cardiac surgery patients. So we're trying to validate that in that population. But radial and femoral adults validated.
Really nice. But let me ask you another question that you showed in your presentation, but I would like to know more. Because you said that because you use multi-beat analyzers, it is stable when we are using this technology in patients with atrial fibrillation. Is it okay? Is it right?
Yes, this was
this is a game changer, as I
correct.
said.
Correct. This was published. Was a study done at Wake Forest University. I think it was published either 2 or 3 years ago. It wasn't actually the primary goal of the study, but they noticed that even with patients who had atrial fibrillation, they were still getting reliable numbers. And I think it has to do with the only explanation I can come up with is the fact that it's analyzing multiple beats and not just one individual single beat. So that's the one study I've seen that from, and I'm sure we'll see some more looking at it over time.
This information is precious because all other monitors have problems with whatever arrhythmia. It's even worse with the atrial fibrillation. But for Dr. Manning, if you could tell us if there are limitations for these methods. For example, if I have a patient with pulmonary hypertension or any kind of right ventricular dysfunction, can I use this method? It's okay?
I think so. I have used this in patients with pretty moderate to severe pulmonary hypertension and RV dysfunction and failure, and have found it to be still very accurate when compared to TEE. The one caveat, I think you do have to have a very nice durable arterial line. So there are patients that are, pretty bad vascular paths that have diminished radial arterial signals. The cleaner your radial arterial signal is, I think the better data you get from the machine. That would be the only thing. So in very low flow states, when your arterial waveform starts to become more sinusoidal, like we talked about earlier, I think the data starts to fall off on that low end of the spectrum. But otherwise, I have found it to be very accurate.
Do you have any comment on the stuff that you did about limitations of the methods?
No, I was just nodding along. You need a good waveform, I think. If you have a bad waveform, whether it be for technical reason or extreme low flow states where you have this dampened waveform, then you're not able to the algorithm's not able to really at that point differentiate what's a diastolic component to begin to do the modeling for that exponential decay. And so in those situations where the waveform doesn't pass internal check, it would go blank. You don't get a number because you could be getting a false number at that point. And so anytime we have a blank screen, a blank dot, no number, one of the first things I do is look at the waveform. Is my waveform okay? And so if you have an underdampened waveform, or sometimes it's just a technical thing, you fix your do your fast flush test and fix your waveform, and after that you begin to get your numbers.
And I'll piggyback on to what he's saying. I think that when the studies are done to validate the brachial arterial lines, and in some patients, we've placed high axillary arterial lines with micropuncture catheters that are quite long, especially in obese patients or patients that we know are going to keep an arterial line for a long time, several days. I have found that the data is almost better because the arterial signal is so clean and so nice and sharp. So I think that fits, and I think that the validation studies are going to show that it's just even better.
Real nice. Let me ask you something that's a personal one. Do you need a central venous line to measure central venous pressure in order to calculate the systemic vascular resistance or not? The thing does just look into the wave.
Good question. The CVP is not needed to estimate the SVR, because that's done from the exponential modeling of the diastolic delay. The CVP, and that's the other assumption Argos makes, it imputes a CVP of 7 as a default. Otherwise you would have to find a way to measure CVP and put that in the Ohm's formula. The reality, it also modeled it and did a sensitivity analysis. The reality is it barely changes the true cardiac index. So I believe the monitor allows you to input the CVP if you want, but it doesn't. When you think about the Ohm's law formula, the difference is negligible.
So it infers that the CVP is 7, and then it calculates on this number. But for example, if I have a much higher, for example, 15 of CVP of 15, does it allows imputation of the number, or it works?
It does.
Yeah, you can put in the CVP. If you want to put in the CVP of 15, you can. Okay. But then the reality, it sort of adds to the friction of now you have to keep updating it each time the patient CVP changes. But and I believe they had to do the sensitivity analysis to get FDA clearance. So even when you change the CVP, subtract that from the mean arterial pressure, it barely changes it's a tiny component of a formula that the difference in the calculated cardiac output is negligible.
Now, one of the things that I have done personally in patients that I don't want to put a central line in, and I still want some index of central venous pressure, I will place a long IV catheter in the external jugular and measure that. Now, that's not as precise as a central venous catheter sitting at the right atrium, but as a trend, I get fairly reliable data that you could put into the retia if you wanted a little more specific, but you don't want to commit a patient to a central line. You have a nice external jugular you can use for IV fluids if you needed to, or blood transfusion. But you could get, I think, a pretty decent marker of central venous pressure at that point.
But at the end, the importance that we have the cardiac output and the pressure, so we can infer in a way what's the way SVR is going. So I have a last question. I see that the audience is a little bit shy to post questions on the chat, but a question for you that use the methods. Compared to the other minimally invasive monitors, whatever monitor, FlowTrack, Vigileo, Pico, Lidico, whatever monitor, what do you think is, Claudia just posted a question, you can both read, and the guys from the presentation published it online, but what's your impression on what of these monitors are better? I don't know. I'm just started to change my views because this monitor, maybe we have some cost to buy the monitor. We do not have to buy the disposables. This may be a major advantage. I'd like to hear from you.
I think in the chat we were having before the webinar started, I mentioned that when I was a fellow in training, I did some of the studies for LiDCO to show, because when LiDCO first came out, you actually had to calibrate with lithium injections, and the calibration had to be done through a central line. And so if you're going to put a central line anywhere, why not put a PA catheter? And so it was a barrier. And the study I did was to compare central injection with peripheral IV injection. And we showed that was comparable. So you now at that time with LiDCO, you no longer needed to do a central line. You could just do your calibration to a peripheral line. And then they've moved on from there since then. With LiDCO Rapid and all of that. My point is every one of these devices has limitations and caveats. There are also some assumptions that are made. And even the PA catheter, which we consider the clinical reference, it's actually, I try to make the point, it's actually not a true gold standard. The gold standard, if you will, is to directly measure with an aortic probe on the ascending aorta. And if you compare the PA catheter to that gold standard or a direct fit measurement, the percentage error is 30-40%. So even our clinical standard has some limitations and caveats that we often don't consider, but just because that was the first one out there, we make this assumption, we assume, or we accept it. So that's my point. And I think this is where, so it now comes down to cost and ease of use and the clinical attributes. And that, like I said, that's what got us at the Cleveland Clinic, because suddenly we now had something that all we had to do was ask the nurse to bring it in and plug it in. You didn't have to spend 30 minutes setting it up, changing the transducer, taking the dressing down, and find some tubing. Oh, we didn't order it somehow, we don't have the tubing. All of that stuff that is just to get you information and taking them away from actually putting on the medications or doing the treatments you wanted. And so that ease of use got our nurses right away. They were like, yeah, forget all the others. And then the physicians sort of agreed, well, since we all couldn't pick one on the other from the other ones that we already had, why don't we all try this collectively? And once that started, we actually never said don't buy any of the other ones anymore. The use just naturally. So I know we still have LiDCO monitors in storage somewhere. The physicians just stopped using them because this one was just so simple to use, and not all you have to do was ask for it and plug and play, and you get your response. And then the clinical evidence is arguably, I think, stronger for when you think about concordance with the PA catheter, stronger for the Argos than some of these other devices. They all have their caveats and limitations. They all have some assumptions, but I think the assumptions that the Argos makes about compliance and CVP are more robust than making an assumption about SVR, for instance.
I think you also have to keep in mind that, this is a tool, and it's a very good tool, but it still requires you as a clinician to have good, sound clinical judgment. You have to be attentive to the context in which you're using it and getting these numbers. But at the end of the day, it allows you as a clinician to be very proactive in how you intervene and to directly intervene where you need to. And I think that's the key, right? So there's a lot of tools, and like he was saying, you got to pick the tool for your institution that works and your clinicians, but it can't undo bad clinical judgment or inattention during the case, right? So if you're going to get the tool, you got to support it with good education and good protocols. I think the two have to go hand in hand.
Yeah. Sure. Guys, we are late now, at least for us here in Brazil. We are over 9 o'clock, and I thank you very much for your real fine presentations. and to show us this new monitor. At least I didn't know this one, and I'm very impressed. I would like to see if this one works well. Thank you very much.
Thank you for having
Pessoal
us.
da audiência.
Thank you. Thank you for having me.
Pessoal da audiência, muito obrigado pela atenção, pela participação, e assim a gente vai encerrar nosso webinar de hoje à noite. Boa noite a todos.